Good afternoon, everyone. My name is Sharon Rounds, and I'm the Program Director for Advance-CTR, and it's my pleasure today to introduce the last of our Advance-CTR Translational research seminars for this academic year. We're really pleased to have Rani Elway here today, who will be talking about foundations of implementation science in learning health systems. Rani joined us on the faculty of Brown almost 4 years ago. She's a professor in the Department of Psychiatry and Human Behavior. She came here from Boston University Medical School. Rani is a national expert in the area of dissemination and implementation, which is hugely important to all of us as we work to improve the care that we provide for our patients. I will say, parenthetically, that I've been so impressed by the growing excitement and interest in this area amongst both trainees as well as junior faculty and senior faculty. So it's really a pleasure to have you here, Rani. Rani's role in the Advance-CTR is she is a co-lead for the Biomedical Informatics Core of Advance-CTR, in addition to all of her other responsibilities. So I'll turn things over to you, and I will say that you can enter questions either into the chat, or if there's a burning issue, that should be brought up right away, we will keep an eye on the chat and bring that to Rani's attention. So over to you. Thank you.
Thank you so much, Dr. Rounds, for that introduction. And I'm so happy to be here to see all of you virtually and to talk about implementation science. So I've had a really wonderful first 4 years at Brown, and I'm looking forward to having more activities in implementation science across the different hospitals, as well as the medical school and the School of Public Health. So just as a disclosure, I am partially funded on our Advance-CTR and also in the VA healthcare system. So I'm not representing those entities in my talks today. So I have really enjoyed learning about learning health systems through the last, I'd say, 5-6 years as the VA healthcare system, as well as many other healthcare systems across the country, have been working towards becoming a learning health system. And this is defined by the Agency for Healthcare Research and Quality as a health system in which internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, and more efficient care, which are the National Academy of Medicine goals, and healthcare delivery organizations become better places to work. There are 6 main goals of learning health systems, and I'm going to just I'm just going to list them now, but we will go through each one of these and show how implementation science is relevant to each of them. So learning health systems have leaders who are committed to a culture of continuous learning and improvement. Learning health systems systematically gather and apply evidence in real time to guide care. Learning health systems employ IT methods to share new evidence with clinicians to improve their decision-making. And they promote the inclusion of patients as vital members of the learning team. Learning health systems also capture and analyze data and care experiences to improve care. And they also continually assess outcomes, refine processes, and training to create a feedback cycle for learning and improvement. This all sounds really daunting, but as we'll talk about, it's completely possible to do this. And I will argue that you need embedded learning health system researchers who are doing this work to help a healthcare system become a learning health system. And you also need these embedded learning health system researchers to have a strong background in implementation science. I will say that if you don't already know, we have a tremendous network here at Brown, which is a collaboration between Brown School of Public Health, Boston University, and the University of Pittsburgh, called LEARN, the Learning Health Systems Rehabilitation Research Network. This is run by Dr. Linda Resnick, who is also at the Providence VA Medical Center. And it really provides support for implementation science and learning health systems research in order to specifically improve rehabilitation quality, value, and outcome in rehabilitation care. They work with a number of health systems across the country, and they have a really robust seminar series. I'm part of the didactic planning group, so definitely go to their website here to learn more about them. I'll be talking about the Query implementation roadmap, as it relates to learning health systems throughout this talk. So a couple of years ago, Query, which is the implementation science arm of VA research, Query stands for Quality Enhancement Research Initiative, developed this implementation roadmap really aligned with learning health system principles. So the learning health system principles are the words on the outside of the circle, and the implementation roadmap are the elements in the inside of the circle. So I'll be talking about the pre-implementation, implementation, and sustainment activities of this implementation roadmap and how they relate to learning health system principles. In 2018, this paper by Forrest and colleagues came out, which had been part of an Agency for Healthcare Research and Quality engaged stakeholder process to develop learning health system researcher core competencies. And so what they did is they identified that there were several different core competencies that are needed for researchers within learning health systems to help make that learning health system happen. They defined a learning health system researcher as an individual who is embedded within a health system and collaborates with its stakeholders to produce novel insights and evidence that can be rapidly implemented to improve the outcomes of individuals and populations in health system performance. This is not that different from what we do as researchers in general, but what we're doing as a learning health system researcher is we're literally working within that healthcare system to help understand what data do we need to collect, what we can then do with that data to improve care, and then do a continuous improvement process to make sure that that care is improving. So the core competencies that are needed are these seven actually that are listed here. I can't go over all 7 of these in this talk, but the LEARN network does go over all of these. But I just want you to see that quality improvement and implementation science are one of the core competencies of learning health systems. So it really is quite true that the implementation is a foundation of learning health systems. So here's a table from that Forrest paper in Health Services Research, where they define this domain of improvement and implementation science. And so in order to achieve competency in this as a researcher, there are these 3 specific competencies that they're advocating for. And they define this domain for improvement and implementation science to reduce avoidable variation in process and outcome and ensure the systematic uptake of research findings in a health system. And this is what we try to do in implementation science all the time. We're really trying to understand the methods, the strategies, the designs that we need to develop in order to increase the uptake of evidence into practice. So this is very much aligned with a traditional definition of implementation science. It's just that it's focused on a specific health system. Each of these competencies refer to specific methods within quality improvement and implementation science that one needs to be able to move this evidence into practice. And we also then need to understand when it's possible to mount larger scale-ups and spread of successful interventions that we've tested along the way. So I'm going to give examples of different research that I've been part of that really help to drive these learning health system goals related to implementation science. So the first learning health system goal that I already mentioned is that leaders are committed to learning and improvement culture. And this is something that is very much in the pre-implementation phase of that implementation roadmap. This is where leaders need to understand what the problems are in the healthcare system that they need to address, who the stakeholders are, and what those best practices are that they need to actually think about implementing further. We often do this through formative evaluation, and that's a method that I'll describe. And that's part of what I just mentioned previously, which is these different methods, quality improvement and implementation science methods that you need to be a learning health system researcher. In addition to doing qualitative work in the formative evaluation, you can also do quantitative work through surveys, and that often involves baseline implementation measurement. So here's the query roadmap again, and we're going to be focusing on the orange part, which is the pre-implementation. What is the healthcare problem? Who are the stakeholders that need to be involved? What are the best practices or the evidence-based practices that we need to use to address those problems and involve those stakeholders? As a definition, formative evaluation is a rigorous assessment process designed to identify potential and actual influences on the progress and effectiveness of implementation efforts. And it really helps us understand complexity of a healthcare system, which is certainly a complex system, and to understand the ways that we can address the difference in context, what adaptations need to be made for whatever intervention it is that we're trying to implement, and then how we can respond to that change. And so this has been something that's been talked about since the beginning of a field of implementation science. You can see from this paper from 2006. And I usually talk to people about using formative evaluation in this developmental or pre-implementation phase, but you can actually use formative evaluation throughout. And I'll give descriptions of how we've done that in other ways too. But right now I'm going to focus on this pre-implementation and developmental stage. The first project I'm going to talk about is a Corey-funded project that actually just recently completed with some colleagues at the University of Pittsburgh Medical Center. HEAL, just by the way, is not the NIDA HEAL. HEAL was an acronym that was used previously before NIDA started to use it. HEAL, in this case, stands for Healing Encounters and Attitudes List, and it's a set of psychometrically valid patient-reported outcome measures. And, as we're talking about learning health system goals and when you're talking about leadership, leadership really needs to be committed to learning what's happening on the ground and to invest in continuous learning and improvement. And so as is required in PCORI projects, and it was quite natural in this case, Dr. Ajay Wasan, who is the vice chair for pain medicine at University of Pittsburgh Medical Center, is one of the co-PIs of this project. And he oversees 7 different pain clinics in the system that really vary in terms of context. Some are urban, some are suburban, and some are rural. And they see about each one of these about 25 patients a day. And they provide a lot of different pain care treatments. And these HEAL survey items had been previously developed by Dr. Carol Greco at UPMC through NIH funding, through PCORI funding. And now we wanted to do a true implementation project where there are no research assistants on the ground, that this is truly a way of getting staff, providers, clinicians, other people on the ground to do the implementation effort, which is quite a feat. There are many different domains to this Healing Encounters and Attitudes List, but one of them is on treatment expectancy. And Carol had found through her prior work that when patients respond to these questions, and we get a little sense of, for example, in this case, what their expectations are for their treatment. Do they feel confident in the treatment? Do they think the treatment will be successful? How they feel about it? Is it the right one for them, et cetera? That you can actually predict from their responses on these types of measures, you can predict how they will respond to treatment and what their eventual health outcomes will be. Some of the other survey items are related to patient-provider relationship, positive outlook, attitudes towards different types of treatment, spirituality. So there are 6 different areas that these survey domains cover. I'm just going to focus on treatment expectancy as an example. In any good project, implementation project, we always have a theory or a model or a framework that is guiding what we are looking for. So in this case, we chose the theory of diffusion of innovation. We really wanted to understand how different stakeholders, patients, providers, clinic staff, perceived the use of these measures in their pain clinics. We wanted to know, did they see this as a relative advantage? Compared to what they normally would do? Was the use of these survey items compatible with their perceived needs and values? Were they of low complexity? You certainly want innovations and evidence-based practices to be as low in complexity as possible because that helps with uptake. So these are the kinds of things that we were looking for in our formative evaluation work, which we have published in Psychiatry Research, and it's available at this link. So what we did is we did interviews with 38 different stakeholders, patients, providers, and some clinic staff. And I'm just going to give you a snapshot of what we did. This was prior to actually rolling out the surveys within the pain clinics. We talked to patients, we talked to providers, we talked to clinic staff, we showed them the different measures, we got their feedback on them. And so here in this matrix, I'm providing some information on what patients told us and what providers told us, and how they perceived it in terms of the relative advantage, according to the theory of diffusion of innovation. Was this something that they thought would actually work for them in terms of responding or using these measures related to treatment expectancy? And so this patient, the top left, felt that using these items on treatment expectancy would be very important. They said, the provider needs to understand that my time is important. When I go to the pain center, I don't expect to leave pain-free. Rather, it just needs to be tolerable or manageable. My doctor feels the opioid problem is due to people wanting no pain rather than managing it. And I do the treatment to avoid having spinal surgery. And I thought that was really powerful, because this is a real, I think, difference between what providers think that patients want from a treatment and what patients actually say that they need. So this person felt that there was a lot of advantage of using these measures. Both patients and providers did, however, also give some concerns about the fact that the items were duplicative, or they perceived them to be duplicative, not understanding how these measures worked. And so there were also some things to overcome, some challenges that we had to explain to people when they were completing the measures, that just because we're asking questions that sound similar often, that this doesn't mean that we're trying to trick you in any way. So those gave us some things to have some action on prior to the implementation. In this project, we did not do any baseline implementation measurement, as I mentioned earlier, from that first learning health system goal, but you can do that. And some new measures have come around in the last few years on looking at these different implementation outcomes, such as acceptability, appropriateness, and feasibility, such as, so does a patient or a provider or a clinic staff member feel like these measures are acceptable? Are they appropriate for the clinic that they're being used in the population? And is it feasible to use these in a busy real world clinic setting? So there are some good pragmatic measures that are available for people to use. So the second learning health system goal is to gather and apply evidence in real time. And this is really related to the implementation phase of the roadmap. And we have some mechanism in the VA healthcare system called the Query Rapid Response Team that can really help us do that gathering and applying of evidence in real time that I'll tell you about. And here we draw more on the improvement science core competency to do this work. So here's our query roadmap again, and here's the implementation, which is the green. So we want to know what strategies we need to overcome any challenges that exist in the healthcare system. We need to know, do we need to adapt these for a specific population or context? And how will we know if we achieved what we sought out to achieve? So in the VA, we have these query rapid response teams, and I have the good fortune, I think, to lead one of these. And so this is when there is a time-sensitive implementation issue for a healthcare system. So maybe there is a new program that's being rolled out. Maybe there is a crisis, such as a pandemic, in which we really need to collect ongoing data. And we need these flexible transdisciplinary teams to do that. So people who have a lot of experience with different types of methods, who can all come together in a short amount of time to answer an important question for that learning health system, for that health system in which they are working. So in our work, we were approached in November of 2020, a month before the vaccines for COVID-19 were meant to go live. And we were asked, will we work with our VA National Center for Health Promotion and Disease Prevention to help them understand what were the barriers to potentially receiving a COVID-19 vaccine in the VA healthcare system. At this point, as you will all remember, people were just really focused on getting the vaccine right, which of course, all of us want the vaccine to be right. But there was very little effort put in at that time into, well, what were people thinking about this vaccine? So we came in to work with this program office within a very large healthcare system to find out what patients were thinking and what employees were thinking about the vaccine. And we did two types of studies simultaneously. We did a qualitative study where we talked to 32 veterans and 31 employees. And we also did a survey study that I'll tell you about in a second. So we always have some sort of guiding framework for our work. And in this case, there really wasn't something that we could just point to and say, this is what we will use. We went back, we went to the literature, we read everything that we could on, people have been doing work on vaccine hesitancy for a long time. Certainly it was not new for COVID-19. And so we went to all of that research and we developed a framework along with an article that was actually published by Derek Thompson in The Atlantic, where we use these 5 vaccine hesitancy categories on the left to really understand what people were thinking. And I'm just going to give you a couple examples of what we heard in our interviews. So from a vaccine deliberation perspective for veterans and employees who told us about this, these are people who were engaged in watchful waiting and they really needed more data on vaccine safety. And so in this case, a veteran told us that he would not describe himself as an early adopter of anything. So he's not the first one to buy anything, try anything. He said, I basically like to sit back and I may be interested in something, a product, a service, a medication, but I'll sit back and watch what happens and see if there's any unintended consequences for the rollout of whatever the product or service or a vaccine or medication happens to be. And so this is that person's natural inclination to do this. And it's not necessarily specific to, in this case, the COVID vaccine. A staff person, an employee, told us about distrust they have in vaccines. And in this case, distrust in vaccines is defined is really distrust in government systems. And yes, this person is a federal employee, but they still have distrust in the system. And so they said, you know, there are a lot of different trials or whatever that happens to approve something. And remember, this is at the stage where it was just emergency use authorization. And so this person saw the emergency use authorization as being something that's not FDA approved. And when something is FDA approved, you know, it goes through the correct channels, the correct process to get approved. And in this case, this person saw that or perceived it to not be approved. So he says, when it wasn't, it's like, what was different this time? What was potentially skipped? And so they had a lot of distrust. We saw a lot of this vaccine hesitancy across the spectrum. We saw probably the least amount of vaccine indifference, but there was something that we heard about in every one of these domains. And we also then got to hear from people who were initially hesitant about vaccines, and then they moved towards acceptance. And so this person says, if I was single, I probably wouldn't have got it. But because I'm married and I have a kid at home and I got to make sure, like I said, my wife's out of work, I got to make sure I'm working. So I just weighed the pros and cons. And I said, it'd be kind of selfish of me if I didn't take the vaccine and then I got COVID-19. Then people would have been like, oh, you should have taken this. And so this person really talked about the altruism that was needed. And so we were able to combine this qualitative data with some quantitative data that we collected. We were able to work with our survey partners in the VA, working with an existing panel of veterans called the Veteran Insight Panel. And we were able to talk to approximately 1,200 veterans, or survey 1,200 veterans to find out what their attitudes and intentions were towards the vaccine. And we learned through this national survey that was really just deployed over about a 14-day window in March of 2021. We learned that those who said that they weren't sure about getting vaccinated were more likely to describe their overall health as well as their overall mental and emotional health as fair or poor. That's the column on the right, and on the bottom, the blue bar there, that they were more likely to report fair or poor health and less likely to describe it as good than those in the other vaccine intention groups. So this not sure group was really something that we felt that we needed to learn more about and to potentially target in our communication efforts. We also took the same vaccine hesitancy categories and asked some questions on the survey related to each one of these. And then we could find out how, if people, you know, endorsed these reasons for getting a vaccine or not getting a vaccine with their intentions, and then we could understand a bit more. So we saw that people who said something about skepticism of the vaccines were definitely probably not and unsure about getting vaccines. And we saw those that said that they had some concerns about the side effects and had, you know, some concerns about using as few of medicines as possible, that they indicated that maybe they would get vaccinated. So there was some movement there. There were some ideas about how we might address this. So we were able to take this data together with our team and with our VA partners, the National Center for Health Promotion and Disease Prevention, and come up with a plan for really thinking about how to move all of these patients and employees who were hesitant about getting vaccines into an acceptance place. And we really drew on Enola Proctor's work for identifying and specifying implementation strategies from a communication perspective. And so we said, we learned on our work that doctors were really trusted. We learned that this altruism was really important. So having some discussion about that altruistic aspect was really something we felt needed to be part of the conversation. We wanted these one-on-one conversations between doctors and patients to focus on vaccine knowledge. We wanted them to try to motivate them through this altruism and societal impact. Our targets were really to get people just willing to have a conversation. We knew that there would need to be more than one conversation, but we wanted them to just be willing to have it, and eventually, hopefully, to get a vaccine in their arm. And so then the analysis would track those conversations as well as the vaccines that were administered. This work was actually something that we then moved into a global scale. We became part of a WHO work group on global vaccine implementation. And what we learned in the VA healthcare system was actually very relevant to countries throughout the world in terms of how to have these one-on-one conversations. So this actually became part of a white paper and presentation to the WHO. So we've really been trying to build on what we learn, bring it back to the healthcare system, and talk about what those next steps are. The next learning health system goals are really all related to the sustainment activity of the query implementation roadmap. And this is thinking about how will people benefit over time and what is the impact on the system, the clinicians who work in there, and really importantly, who's going to own the process, because sustainment is only going to happen if someone at the clinic level, the organizational level takes over and really owns that activity. So when you talk about a learning health system goal of employing IT methods to share evidence with clinicians to improve decision-making, I'm going to take you back to that PCORI project that I was talking to you about. Those HEAL measures on treatment expectancy and other things were built into the electronic health record of these pain clinics through this open source web-based patient-reported outcome application called QUIRE that comes out of Stanford. It's called the Collaborative Health Outcomes Information Registry. It was really optimized for patient-reported outcome measures. And a lot of people use PROMIS measures in these, but we were adding these HEAL measures, this treatment expectancy measures, into it. And patients were able to complete these measures prior to coming to the clinic using either an email that was sent to them, email link sent to them, or they could use a clinic iPad, and then their results would be uploaded into their electronic health record that the provider could see prior to the patient coming into that exam room. And then ideally, what the provider would do is that they would look at these measures over time. This is what their clinician report would look like. They would look to see, well, what were their responses to measures previously, the last time I saw them? What are their responses now? Had things changed over time? And the idea was to get them to look at this and think, well, gosh, their treatment expectancy has gone down. Maybe whatever I prescribed for them previously isn't working and they're feeling really down about it. And I don't think this is going to be successful. So maybe they would have a conversation about that. So that was our goal, was to really improve the conversations between patients and providers through embedding these questions into the electronic health record. It's really hard to observe this. So we had to look at other outcomes. So a year after launching this in the electronic health record, getting patients to complete the measures, getting providers to actually have that conversation, look at the scores in advance, have that conversation. We can only hope that things changed for the better, at least attributed some of it to these measures that we were using. We saw a big increase in referrals to integrative medicine and to either psychiatric or psychological services, and a big decrease in opioid prescriptions, orders for injections over time. We actually also saw a decrease in physical therapy and occupational therapy for these patients who people were talking to about these measures. We don't really know if that's because they were getting more integrative medicine, such as acupuncture for their pain instead, but it's just something that we need to probably explore more. We did see a decrease in the number of ER and urgent care visits per pain patient in general, but these visits were not necessarily coded as being pain specific. But it gave us some signal that perhaps putting these measures into the electronic health record, having patients complete them, having providers look at them, bring them into a conversation, maybe was having an impact on how treatment was actually being delivered to them. The fourth learning health system goal is to promote inclusion of patients as vital team members. And this doesn't mean just doing research on patients or having patients be part of the group of people who you're collecting data from, but this means like an active member of the team. So how can a patient be an advisory board member? Can they be a consultant on the project? Can they even be a co-investigator if that is relevant? I just want to point you to a special issue in the Journal of General Internal Medicine that just came out in April of this year, and it's a joint PCORI and VA promoted journal, really trying to look at patient engagement and research. And this is a paper that we have in there where it's just a perspective piece, but we're really talking about the process that we've gone through in our own research efforts to involve stakeholders as communication partners in our research dissemination efforts. So really how to engage patients and also community members along the way so that at the end of the research, they are the ones who are actually sharing the results with others. They are the ones who are telling people about the evidence. And so we've learned a lot that researchers are not the best disseminators of evidence, that they're not actually the ones that patients and community members want to hear from, that it's really the end user is the better person to disseminate information. And so how can we do this? So we talk in this perspective piece about ideas for identifying and involving these different community-based people along the way in our work so that they can be the ones who are really disseminating. In my own pathway, my own personal pathway of involving patients and community partners in my work started with collecting data on patients. And I think that is a good starting place if people are not yet doing research activities that involve talking to patients or families or community partners. And in one of my first VA projects, we were trying to understand why veteran patients in primary care who had screened positive for depression were still not getting treatment for depression. We just didn't know why. So we did some surveys and we also did a subset of interviews. And this veteran just literally hit me over the head with this comment by saying, I know I'm depressed, but I'm not getting treatment because I don't want that kind of treatment. I don't want drugs and I don't want to talk to anyone. I want yoga, I want meditation. Why won't the VA give me that? This was in 2010, maybe 2009, when this was not happening in our VA healthcare system. Veterans were not able to get yoga and meditation. It was not something that was being offered. I started to write grants on this based on this quote and based on some other things that I had read. And I thought, this is exactly what we need to engage veterans in treatment and to actually promote their health. And I was completely laughed out of the review committees. And no, the VA was not ready for this. So I found some like-minded people in the VA. We kept trying to push this. But what happened was the senator from Rhode Island, Sheldon Whitehouse, actually pushed and passed the Comprehensive Addiction and Recovery Act, or the CARE legislation of 2016, which had a whole section on complementary integrative health specific to the VA healthcare system. This subtitle C actually said to the VA healthcare system, you will invest in research, clinical practice, and education on the use of complementary integrative health as a non-pharmacological treatment for pain and for mental health in veterans. And boom, there we had it. There we had this literally a mandate from Congress to do this work, and all of a sudden there was funding for it. And so my colleagues and I were able to launch the Complementary and Integrative Health Evaluation Center, something I've done in partnership with Stephanie Taylor at Los Angeles for many years. And we've been able to study the effectiveness and the implementation of complementary and integrative health since 2017. And this is very much related to this fifth learning health system goal, which is capturing data to improve experiences and care. And so what we did as part of this complementary integrative health evaluation is we selected two very different VA healthcare systems to sort of watch and learn what happened to veterans as they started to engage in different complementary integrative health practices. They could be involved in anything. We were looking at yoga, Tai Chi, meditation, acupuncture, healing touch. There are a lot of different things. I think there were 27 different things that we were looking at. And it didn't matter what they were doing, but they needed to continuously do it in order for us to collect some information on it. And so we had 119 veterans that we observed over a 1-year period. They completed surveys on their patient-reported outcomes. We looked at their overall physical and mental health. We looked at pain intensity, perceived stress, looked at their engagement in care at 5 different time points. So we looked at baseline, 2 months, 4 months, 6 months, and 12 months. And we really wanted to see how did these things, their physical and mental health, their pain intensity, their perceived stress, engagement in care, how did it change or not over time as a result of participating in any type of this complementary integrative health? And what we found was that those who participated in yoga actually reported a decrease in perceived stress. Those who participated in meditation reported an increased physical functioning throughout the 1-year period. And what surprised me, and I still have not yet engaged, but I keep thinking I need to do Tai Chi because Tai Chi was so effective for these people. They really reported an improved overall physical and mental health as a result of participating in Tai Chi. They had an improved ability to participate in social role activities early on in our assessment. And they also reported reduced anxiety at the 2 and 6 month mark. So this was information that we were then able to bring back to these 2 healthcare systems where we were collecting this information and share it with the leadership, share it with the providers and say, this is what we're learning. And then they, as they have conversations in primary care with their patients about, well, what can they do to address their stress, their physical functioning, their mental health functioning, what can we do? They can share this information with us. So it was really a true practice-based research where we're able to capture data, bring it back, share it, and then have a continuous cycle of trying to use the data to improve these experiences in care. And that's related to the 6th and final learning health system goal, which is to create feedback cycle for improving care. And we do that through process evaluations. And that's what we were doing is we were collecting ongoing data. We really need to understand how different activities have been implemented in our healthcare systems. We need to understand, what components of the logic model are existing, like when we input something, what is the output from that? We need to understand, and specifically, what are the barriers and facilitators to any of the efforts that we're trying to put in our healthcare systems to improve care? So you could say that some of that work that I just told you about with the complementary integrative health was a process evaluation, but I also just want to bring you back to the PCORI project, because I told you about the formative evaluation where we interviewed 38 stakeholders right at the beginning before launching those surveys into the electronic health record. But we also continued to collect that data along the way. We did process evaluations halfway through and at the end to learn what was still a challenge, what was going on, what else could we do to help the clinics in addressing treatment expectancies of these patients. So as we did these process evaluations, so about 5 months after we launched the HEAL measures into the electronic health records, we did, over a very quick period of time, 2 weeks, we did 45 interviews at the 7 different clinics with patients, providers, and clinic staff to learn what were some of those challenges. And one of the challenges we heard from clinic staff, in particular, the people who work at the front desk when the patient comes in, is they were like, the patients don't understand why they have to complete these measures, and I don't know what to do for them. And so we created these FAQs, these FAQ sheets, and we asked the clinic staff to hand them out to patients so that the patients might actually understand more about what was happening. Through these process evaluations, we also found that we really needed to just explain more about this effort. So we had some ongoing educational meetings. Dr. Wasan, who is one of the PIs, actually had a full clinic retreat to talk about this. He created journal clubs with the clinicians to talk about the benefits of some of the other treatments for pain, such as acupuncture. And then we also just had these lunch and learn sessions where we brought, you provide food, people are really happy. So we provided food and we hired a coach who was trained in motivational interviewing to conduct these sessions with clinic staff. These could have been like mid-level clinicians, the front desk staff, any of the attendings, to just really talk about like what is the benefit of asking patients about how they feel about their treatment. We on the right side just shows some of the barriers and facilitators we collected along the way. We also learned from them that maybe it would be helpful to have some description of how they should be doing this. They really didn't know how. And so we created our own YouTube channel. You can see there are 3 subscribers. I'm one of them. And we created these different videos to really help the different providers, the staff, et cetera, at the 7 clinics really understand how they should have these connections with patients, how they can talk about it. And so the videos feature Dr. Wasan, who's one of the PIs. And the video on the right is where he's literally having a mock discussion with a patient. That patient is actually one of our research team members, to talk about treatment expectancy and what it means and why it's important, and to understand that patient's perspective of it. And so each of these videos was, I think we created, 6 of them, only 5 are here. We created 6 videos, and over a 6-week period, we sent 1 video link to each of the 7 clinics and said, please watch this. We asked them to complete this very short red cap survey to get their perspectives on it. Any clinic that watched the video the most got coffee and donuts as a prize, just to collect ongoing data that we could then use to improve the process by which we're asking these clinics to do this work. So those are the 6 learning health system goals, and the different methods that I've shown you are all built on implementation science about how to address that. But the question that you might have, and what I had as I was thinking about all this, is how do you connect all of this in one implementation science study? Because I've showed you a variety of projects. How do we do this in one study? And the answer is, it's really through hybrid designs that we can do this. And a hybrid effectiveness implementation study is something that implementation science developed. This paper by Jeff Curran and colleagues from 2012 is really the seminal paper describing how to do this. And we talk about hybrid designs in 3 ways. There's a hybrid type 1, which is your standard randomized control trial, effectiveness trial, where you're doing everything that you would do in a normal RCT, testing the effectiveness of an intervention, but you add on an aim 3 to observe and gather information related to implementation efforts that are going to help you in your next trial. Then there's a hybrid 2, where you have a dual aim of looking at both the effectiveness of an intervention, as well as trying to understand more about the implementation strategies that you're using to get that intervention into practice. And those implementation strategies are the things I just told you about: the lunch and learns, the FAQ sheets, the motivational interviewing, the journal clubs, the educational retreats. All of those things are strategies, are methods that we use to increase the uptake of an evidence-based intervention that we want someone to use. And then the hybrid 3 is really where we flip it. And the primary aim of a hybrid type 3 is to understand what implementation strategies work the best to get our evidence-based practice into care. We still keep our eye on the effectiveness of our intervention, but by this time we know that something works, and now we need to figure out how does it work best. And so that's really what is the way to put all of this together, is in a hybrid type 3. You have the opportunity to do a continuous learning where you're feeding back data. You have an opportunity to really put things into an IT format for easy access and easy learning of the clinicians involved. All of the things that we just talked about from a learning system goal are represented in a hybrid type 3 trial. And we're doing this in the VA. This is a very big 5-year program that I'm part of as one of the PIs, where we have 3 evidence-based practices. Each one of these is a hybrid type 3 trial in itself. Each one is being rolled out in 6 different sites. So we have a total of 18 sites in which we're trying to get one evidence-based practice up and running. My job is where the arrow is. I'm running the implementation core. I'm running the rapid response team that I just told you about. I'm running the mentoring core to train new people along the way in implementation science and learning health systems. And our job is in the implementation core is to make sure that we're following that query implementation roadmap of pre-implementation, implementation, and sustainment. We have activities that each of our each of our projects are working on, even though it's a different evidence-based practice that they're trying to get delivered into care, they are all doing similar pre-implementation activities, implementation activities, sustainability activities. A lot of this is exactly what I just told you about: qualitative interviews, baseline implementation assessment, defining what implementation strategies are needed in order to move something into care, and then focusing on sustainment. What is this going to cost when this becomes part of regular practice? And who can we convince that they need to adopt this and own this process? So we are using a different framework in our work because we're trying to focus on sustainability. And that's what you're really doing in a hybrid type 3. You're really trying to say, how can I take this evidence-based practice and make it sustainable over time? And that really requires a fit between the intervention, whatever it is that you're trying to implement, that evidence-based practice, the practice setting. So in each of our projects, they're working in 6 different settings, 6 different clinics. So they have to take into consideration all the dynamics of that. And then they have to think about the ecological system, which is everything that's coming at us from the outside, like the laws, the policies, the regulations. A perfect example of the ecological system is that CARA legislation. I was trying so hard to get complementary integrative health research done with veterans, to get complementary integrative health practices part of the VA healthcare system. But I couldn't do it until there was a change in the ecological system. And in my case, it was literally an act of Congress. So that is really important. When things change, when Medicare and Medicaid changes laws and they decide that they're going to reimburse for certain activities, that's when sometimes change matters. And so you always have to be thinking about that ecological system as well. And in our work, each project is using 2 different implementation strategies, and we are assessing how those work. So these implementation strategies are similar to the kinds of things that I just told you about in terms of education that we were doing in the PCORI project, how to engage in the patients, how to train staff, and how to do these different practices. So we also need to do assessments the whole time that we're doing these strategies in order to understand what's working and what's not. And so we are using some of those measures that I told you about. You can see here, this is just a pretend shot of our dashboard that we are collecting data on across all 3 of our projects. We're looking at acceptability over time. We're looking at appropriateness over time. We're looking at feasibility. And we're also looking at organizational readiness for implementing change, which is not a measure I told you about. For each project, we're trying to understand how these change as a result of those different strategies that we're trying to put into place. And if we see that a particular project is not making any changes for the good, we need to go back in and rethink what is it that we need to do in order to make those changes. What changes can help the clinic staff, can help the veterans, can help the patients on the ground actually engage in this practice that's going to improve their care. So it's this constant monitoring and this continuous learning that's really essential. Obviously, if you're in a healthcare system, if you're part of Lifespan or Care New England or Providence VA or whatever healthcare system you're in, you do not want to be this complicated when you're trying to convince a healthcare leader that a learning health system is the way to go. So what I would say is this paper by Jeff Curran, who is the author of that seminal paper on hybrid designs, created this, this really helpful short article called Implementation Science Made Too Simple, a Teaching Tool. And what he really does is he talks about what are the essential ways of talking about implementation science so that anyone can understand why it's important. And here, this is where non-scientific language is really helpful. And so it's kind of been a joke among the implementation science crowd about how Jeff Curran talks about implementation science, but it can be really helpful. You don't have to just say the thing, but whenever we talk about practice and innovation, we say this, we need to get the thing into practice. We need to know whether the thing works. That's our effectiveness. We need to know what is the best way to do the thing. What are the strategies that we need to do the thing? And then how much and how well, what does it take to do the thing? Those are all the main requirements of implementation science. And so this paper could potentially be very helpful when talking to someone who is not an implementation scientist, but you want to try to get them to think about the different ways that a learning health system can evolve wherever it is that you work in terms of healthcare. So I'll just end there and say that this work is not possible without a lot of different people. And so I thank all of them. And I'm happy to take any questions that you might have. Thank you.
Fantastic. Thank you so much, Rani. This is really great. So I'm going to take a chair's prerogative as a clinician. I know that if someone is monitoring how frequently I provide vaccinations to my patients, then I'm going to change my behavior and provide more vaccinations. So the question is, how do you avoid this so-called Hawthorne effect when you're evaluating the results of an implementation effort, and does it matter?
Yeah, well, I think the doesn't matter part is really important. So it's really important to say that all of this is happening in a real world setting, right? These are not research studies. They are implementation science studies, which often come under a quality improvement hat. And so we want to know, what does it take to get someone to do something? And if in your case, it takes observing you, or it takes like an audit and feedback approach where we say like, Dr. Rounds, last week you had 5 people vaccinated, but this week 10, great job. If that's what it takes, then that's a strategy, and that's great.
Okay.
You know, and so it's not a Hawthorne effect in that we are not looking at effectiveness in the same way that people are in a effectiveness research trial or efficacy trial. We're not trying to decide, does something work? Like the vaccines were decided through trials, they worked. Our job was to get them into practice. So what is it going to take? And that was true with everything, you know, that pain clinic project, that wasn't even a trial at all. That was just a true, let's get something into the clinic and make it work. So we kept trying to learn from people, what is it going to take? So sometimes incentives are what it takes. Sometimes it takes, like, for every shot, we'll pay you, 50 cents. I mean, I don't know, you know what I mean? Like, financial incentives are a real implementation strategy. Whether it's a mandate from above that says that takes more of a stick approach. If you don't do this, you will be penalized. Sometimes those are the strategies that work. There are a whole list of strategies that can potentially work. And our goal is to find out which ones might be that.
Okay, fantastic. So a question from Dr. Duarte Velez. How could you explain a little bit about how the control group site looks? What is going on in parallel with the centers or sites randomized as control sites? What is similar and what is different from the experimental sites?
So I don't know if Yovanska is talking about the Query program or the PCORI program. The PCORI program had no control sites. There were, because it wasn't a trial. It was trying to just get something into practice. In our hybrid type 3 trials, they are randomized to receive one set of strategies over another. So there is no control group in your usual way. The control groups are not based on intervention, they're based on strategies. So, of the 6 sites, 3 might start with one bundle of strategies and 3 will start with another. And then there's going to be a crossover where then we switch strategies. So the randomization is on the strategies as opposed to the intervention itself, which is actually sometimes a very complicated thing to talk about in terms of hybrid type 3s. But at that point, we know that the interventions work. The effectiveness aim is not our first aim. The first aim is which set of strategies works best for increasing the uptake of that intervention.
Let's see. I don't see other questions in the chat at the moment. I want to encourage everyone to chime in there. Yeah, not seeing any. Am I miss and Oaxaca, make sure I'm not messing up here. Missing.
No, you're good. You're good.
Okay, thanks. Okay, well, in that case, we'll thank you so much once again. I learned a lot. at working in the VA, I've experienced quite a few quality improvement efforts, and I now am finally beginning to understand what it is that's going on. So that's really great. And, you know, and I know that there's also huge interest in improving care in all of our healthcare systems. So I think if we can approach it in this thoughtful manner, that's really a step forward. So thank you once again. And
I will say that it's you know, what we do in the VA versus another healthcare system. So everything that I used in the UPMC, the Pittsburgh Medical Center project are still the same things that I would do in a VA. So the setting of the healthcare system, you know, in implementation science, we have a set of methods and strategies and study designs that we use across disease areas, across settings. Our goal is to find out what just fits best. So it's not like you need to feel like, oh, I don't work in the VA, I can't do what you just did. No, that's not true, because that's exactly why I showed a CORI project that was non-VA, that was focused on a large healthcare system, but not dissimilar to healthcare systems that people work at here in Rhode Island. So it's definitely, you know, I am an implementation science faculty member in a lot of different programs that focus on cancer, HIV, different social determinants of health. I teach the same things no matter what the context is. So it's important to just recognize that these are all transferable methods and strategies.
great. And I will close with a comment that in the chat, that if there's interest out there on a general implementation science consultation, you can submit a consult through the Advance-CTR service portal request that's on our website. And that's a service that's available to faculty at Brown and the University of Rhode Island and in our healthcare system. So once again, thank you, everyone, and we'll see you next fall. Bye-bye.
Thank you. Bye.